Welcome to the latest edition of Exploring Health with Cleveland Clinic London. Thank you to Cleveland Clinic Philanthropy UK for supporting this podcast. I'm your host, Kash Akhtar, a consultant orthopaedic knee surgeon. Today's episode is all about spinal health. We'll be discussing how to stay strong, what to do when things go wrong, and how spinal injuries are treated from rehab to surgery. So if you've ever struggled with back pain or a gym injury, or you're a GP, a physio, or you're just curious, then this episode is full of practical tips and expert insight. Joining me today is Mr Alexander Montgomery, a consultant orthopaedic spine surgeon here at Cleveland Clinic London. He's a specialist in spinal injuries and sports injuries, and he has worked with athletes from the grassroots to elite level. He's here to help us unpack what really matters when it comes to spine protection, performance, and recovery. So Monty, we've never met before, have we?
Once or twice, like over the last 10 years. Yeah, NHS, private, one place to another place.
It's a real pleasure to have you here, buddy. It's not often I get to chat with mates.
Yeah.
We don't even talk about spines. We can just catch up and see how you are.
Yeah, exactly.
The plan for today, what I want to do is I want to talk about the common mistakes that people make that can lead to back and neck injuries, how to protect your back health long term, and when surgery is the right option and when it's not.
Yeah.
Sound okay?
Yeah, sounds good to me.
Can we start simple? I've got into training and lifting in quite a major way recently.
Yeah.
I mean, I don't like to talk about it. And people are basically saying that deadlifts are bad for your back.
Yeah.
I hear that a lot. I've heard it from neurosurgeons.
Yeah.
What's your take on that?
That's a really common question. It's a really good question to start with. I'll start by putting the positives out, that deadlifts and probably kettlebell swings are probably the most efficient way to build your posterior kinetic chain, which is a simple way of talking about kind of back muscles, glute, hamstring, maybe core as well. But you know, your posterior kinetic chain, the main stabilizer of your pelvis and your lumbosacral spine. And that's probably surprising to hear. The problem with it is that you're at higher risk of injuring yourself from these sports. So with a deadlift, for instance, you need to get your technique absolutely right. You need to have adequate knee range of movement. You need to have adequate hip range. You need to have adequate ankle range of movement. And your technique needs to be spot on. And you need to build your strength gradually. And every individual has a point at which your technique has to be perfect. So, for instance, for me, I can go by with a 90%, 80% technique, maybe a few things wrong, up until about 60 kilos. For me, after that point, I need to be perfect.
Yeah.
If I'm not perfect, then I risk injuring. Where does it go through? Straight through the L5-S1 disc, 19 times out of 20. You know, like most deadlift injuries are L5-S1.
So if you deadlift with poor form, can you give yourself a disc prolapse?
Oh, yeah, absolutely, yeah.
Right.
It's probably one of the single most common reasons why you get an acute sudden prolapse of a normal disc, not like gradual degeneration and bulging and then suddenly tipping over and becoming a prolapse, which is the most common thing. But otherwise, normal healthy disc, suddenly getting prolapse, the deadlift is probably the most common reason why people get that. But it's an amazing way of building your posterior kinetic chain.
Yeah. Technique is key. Because I was lifting 100 kilos this morning and I was feeling something in my back.
Yeah.
And I just thought, well, I better hold off. And I was wondering if I should get a lifting belt. I don't know if those things actually work or if they're just kind of psychological.
Yeah, so that's a really interesting question as well. So I've had that conversation with my strength and conditioning coach, who's also doing a PhD in strength and conditioning for back pain, which I'm helping her with. So I can talk about this forever.
Yeah.
So I think if you're having to use straps on your hands, if you're having to use a strap around your waist, then you probably shouldn't be doing it.
Right.
You know, I think you're pushing your body beyond where it's comfortable being.
Yeah.
What you just said is what most people don't do, which is they get a slight niggle. I go to the gym as well, as you know.
Yeah.
I'm there most days doing S&C stuff. When I get a slight niggle, I stop.
Yeah.
Most people are like, oh no, I've got to push through because my goal is the goal.
Yeah.
The goal's not
the number's the number I got to get to.
The goal is not your goal. Your goal is to do very gradual, slow improvements month on month, almost so much so that you don't even notice it. And that your body doesn't notice it. As you know, there are many parts of this. There is like your tendons, your muscles, your knees, your hips. There's your proprioceptors. There's your mitochondria. There's your muscle mass. There's so many things that go on you don't even think about when you're doing that exercise.
No, I think you're right. A lot of people are in a real rush to progress. And the fact is, anything above zero compounds. And so if you have a small incremental increase, that's all that you need, isn't it?
Yeah.
And there's also an argument to plateau and get strong at a certain level and then work your way up to the next level and stay there.
Yeah.
That's good advice.
80% of the time, you're going to be doing 80% of your capability. Yeah. You'll have moments, I don't know, once a month, once every 6 weeks, you go, wow, I'm on it today.
Yeah.
So today I'm going to push it. But when you're not on it, when you're tired, stressed, works, you slept late. These are all the trigger points. They raise
Yeah.
your cortisol, they raise your inflammation, they make you stiffer, they make you more susceptible to injury. Now you're doing it, you know exactly what I'm talking about,
Totally,
right?
no, and I did it before, and I recognize it because I see it with knee injuries as well.
Yeah.
It's when something's out of kilter that you're more likely to have, when you're not concentrating, when the conditions aren't right, when you haven't warmed up properly, when you are at risk of getting an injury to your knee as well.
Yeah. So I'll give you a perfect example on the deadlift. So I used to do it. I would be happy to do it now again. It's just my S&C guy got me on double leg press and say, try this instead. I think this suits your body better because it doesn't suit everybody. I've made phenomenal progress in 3 years from a pathetic 60 kilos to up to 170 now. And about 6 weeks ago, I went on and I put it too low. You should always go double leg press high, put it too low. And I was on 110, 120 as a warm up. I guess it was medial meniscus. I felt something go in my right knee.
Right.
Twinge, slight twinge.
Yeah.
But it kept going. I was like, that's it.
I
Forget
can sort that for you.
That's why I didn't mention it before.
Come along. Listen, what's the difference between core strength and core stability?
Yeah, very good point. So core strength is you're just building muscle mass and what people think are the core. It's a bit of an 80s term, core. What does core mean? It's like what they use in the 80s to protect your back and to have a six-pack. So you're just building muscle mass is strength. How much can you do? How much can you lift? If you had a objective way of measuring it, whether it's one of those machines where you bend forward or whatever, that's strength. Stability confers actually what are you doing to your body? What support are you offering your back or your body in that area? For me, core strength is 20% of back stability. You imagine it like a rectangle-shaped, splintered object, and the core is, your muscles are just at the front there. You've got your pelvic floor at the bottom, you've got diaphragm at the back, and then the big stabilizers behind the glute, hamstring, and those other muscles. And then the other muscles in the back. You've got many parts of that. And people forget about the pelvic floor, the diaphragm. These are all parts of that splint. You're more splintered when you breathe in, because you've got air in your diaphragm.
Yeah.
So
your core's more rigid.
Yeah, exactly. And so core is what people think of as core. The layperson, I think, is your six-pack.
Yeah.
Which I think is 20%. And you can be too tight on your core as well. It's about balance. Flexibility is the key. I always say that with anything. Range of movement is the key. Without that, you can't do anything. Without that, you can't activate certain muscles because certain muscles only activate in certain positions of range of movement.
Yeah.
And then when you have that activation, then you can slowly, progressively build strength. And that's the value of like reformer Pilates. I'm a great fan of that one.
Yeah, that's the thing. A lot of spine surgeons love reformer Pilates. What is it about reformer as opposed to yoga or normal Pilates that you guys love so much?
Yeah, so the reformer has the slings and springs.
Yeah.
In layman's terms, and they're boards, they're different machines you can use, and essentially when you use the slings and springs, it gives you carryover in range that you can't normally get without the sling and spring. So you get greater range, and it provides that resistance on the way back.
Right.
So you come out and you think, oh, I was doing nothing. This is rubbish. I'd rather do deadlifts. Then the next morning you wake up and go, oh gosh, what's going on there?
Yeah.
And you feel it here and there and everywhere. And there are different aspects to it, and there's loads of different techniques, and people have made PhDs out of Pilates. Yoga puts you in certain positions sometimes which are not great for the back, mainly hyperextension. So there's a lot of hyperextension yoga.
Yeah.
Certain positions that are not ideal. Mat-based Pilates is fine, totally fine, but it's kind of an extension of physio.
Yeah.
So I think yoga is for the person that doesn't have any spinal issues. If you've got rid of your issues, you're now normal, your range is pretty good, then you go to yoga. It makes me laugh that most people that go to yoga are hypermobile.
They really are. I see that all the time.
Yeah.
I mean, it's almost like self-selecting, isn't it?
Yeah, it's
I'm
like
really
you
flexible.
don't need yoga. People like me need yoga.
Yeah. Just to put your socks on.
Yeah.
So you're talking about the things that you like. Are there any movements that you warn people not to do?
Yeah, I mean, it depends what the issue is really and what their body type is. So I had a well-known professional tennis player who had a autofusion. So they were born with a fusion at the base of their spine, and they're tall. And so that creates a hinge at the L4-5. The bottom layer is fused, and actually the sacral joint was partially fused. A bit odd. And this person's main exercise was a deadlift. And I just said, look, can I watch you do? And you could see the hinge happening at that point because tall person.
And huge load.
Huge load, hinge point. So really it would be based on their body shape, what their symptoms are, what their scan shows. There are certain things you shouldn't do, I think. Like there's this thing called a catch lift. I think it's called a catch lift where they jump.
Yeah.
And they lift. Except most people actually don't understand what the point of it is. Your feet should be on the ground at all points for a catch lift. You're putting your toes into plantar flexion and you're catch lifting. But actually, you see people jumping, whole body off the ground, landing. Oh my God, that's really bad.
Makes you wince.
Yeah. I think kettlebell, you need a trainer, and you need a trainer who knows kettlebell swing, who knows exactly what they're doing. Again, probably the most efficient way of building your posterior kinetic chain, but actually I'd say the easiest way to damage your back. Because you walk into a gym, there's always someone doing it, right?
Yeah.
And they're normally doing it wrong.
It's not always under control, is it?
No, I think most of the time when I see it, you look at them and I just look away. You just see them hinging at L5S1.
And then going back to your point, because it's away from the body, there's a large lever arm. Yeah. So the forces are really big, aren't
Massive lever arm. So just keep it simple. Just keep it simple. If you can't do one thing, do another thing. Do a lift close to your body, and it's nuanced, right? It's not just, lift something like that. Keep it, you've got to know where your elbows are. You've got to know your wrist position and lift close to your body. If you're going to do something away from your body, make sure someone's watching you and your technique is spot on, and have a mirror on the side so that you can see your back. You think that you're keeping your back straight while you're doing a deadlift and you're hinging, but actually you're not. You're hunching over and, so you need something to reflect on.
Yeah, and also it just lets me check my hair.
Yeah.
So you've talked about things in the gym. If we move outside the gym, what are the most common spinal injuries that you see in sports?
So different sports. So let's say in young athletes, so anywhere from even 10, but let's say 14 to 23. Obviously the most common game everyone plays here is football, and there's cricket as well. Or
soccer. We have an international audience now.
Yeah, that's right, soccer. So pars stress injuries they're common, not just common. We now realize there's an epidemic of them. They're way more common than we ever knew. And this is a research interest of mine, which I want to look into.
Can you just explain what a pars fracture is?
Yeah, so the pars bit of the bone is the link between the back of your spine and the front of your spine, I guess in simple terms. So some people are born with a pars defect, which means there's no connection. You think, oh my God, that's bad. Actually, you don't notice it most of your life. That's a separate thing. You can create a pars stress injury, which is just bone bruising, what we call edema, which is separate. You can get pain from that. And then there's pars fracture, where because of repetitive motion, you get a fracture there over a long period of time. And we now know, because as you know, the football clubs, when they come out of the academy, they routinely screen asymptomatic people that don't, kids that don't have symptoms. And then they find all these pars fractures, and they're everywhere. There's an epidemic. For instance, in September, in the first days of September, I got about 14 referrals from the Premiership for pars stress fractures because they were screening everyone before the season started. It was incredible. And it's not just in this country, because lots of 17-year-old Brazilians and Argentinians come over because they want Premier League experience. They're not quite at Man City level or Liverpool level.
Thank you.
Sorry, I thought I'd better mention that.
I appreciate it.
But they want to play in a team that's going to give them a lot of game time.
Yeah.
And then they screen them and go, oh my God, you've got pars fractures everywhere. They sent to me, what should we do? He's got no symptoms. So those are really common, pars injuries.
So when I hear the word fracture, I think most people listening hear the word fracture, I think something is broken, it needs to be fixed.
Yeah.
Do they need surgery?
No, most of them don't need surgery. So something like figure is 86% don't need surgery. They do better when you don't do surgery, which people say, of course, that's true. No, well, some things do better when you do surgery. Well, I won't go into ACLs or whatever, but, they do generally better if you don't have to do surgery. And something like 86% of them don't have to do it, but it is a bit like an ACL now. So when I have a chat with the physios and the sports docs, we look at it as a long-term thing. Now, you're not going to get back in 3 months if it's an acute thing. If you're lucky, it's 6 months. I think the average is 5.5 months. So it might take 9 months to get back.
Out of playing and competing, 6 to 9 months for rehab.
Yeah, exactly. Yeah.
Okay.
So you progress it based on symptoms and scan.
And even though there's a disconnect, as you mentioned, between the front and the back, as it were, that's without having that reconnected, it's okay to build up and go back to sport?
Yeah, so they can often build up scar tissue around it. So you get a kind of stable non-union. So it's not bony unified. Some of them do bony unify. Yeah. You can get a stable non-union where it's scarred up, and those are fairly stable. I know, because I've gone in and had to operate on these. You go, wow, this is a lot of scar tissue around here. Yeah, so you kind of build them up. There's lots you can do. The main thing with pars injuries, because it's at the back of your back, is avoiding things that do hyperextension. So a lot of football is hyperextension. Avoiding rotational exercises, so stop-start. So it's all linear-based exercises when you do it.
Until they're better and they can go build it back in.
Yeah, exactly. So that's football. Collision sports like rugby, obviously, is neck injuries are the most common. And if you're a front row forward, the guy at the front of the scrum, there's a lot of American football data on neck injuries.
When you say neck injuries, are we talking about fractures, broken necks?
Yeah, sorry, good point. So there's different types. So there's probably the most common is where it slowly wears with time. And wear in the spine means the channel actually narrows, the bone grows in response to stresses. The disc might bulge, so the combination of the two means that it's narrowed. And in especially the guys who have the most collision with their neck, you can get multiple levels where there's foraminal narrowing, where the channels are narrowed and you get nerve impingement. There may be no symptoms for a long time, and then suddenly something appears.
So, and if the nerve's being pinched, that's the time where somebody will start to experience pain shooting down their arms, into their hands, and possibly even muscular weakness in extreme situations.
Yeah, exactly. Or the shoulder blades. So don't forget the shoulder blades. So one of the most common presentations of nerve symptoms from the neck are actually into the shoulder blade.
Yeah.
That's sort of C5, 6, C6, 7 area. But yeah, that can happen. And then the second most common is a disc, acute disc prolapse. That can happen where otherwise normal disc prolapses. Sometimes you do see that. And the good thing about those ones is most of those recover. Whereas if it's been there a long time and it's long-standing, there's a bit less likely. And then much less common is a fracture in the spine. Right. Occasionally that happens.
Yeah.
But yeah.
And can I ask you what a stinger is? It's a phrase I've heard a lot, but could you just explain it for everyone?
Yeah, stinger is a bit of a layman's term. So
that's
stinger,
why I'm here. I'm a layman.
Yeah. So it's something, you're right, rugby, in rugby and sports like that, they often hear, I got a stinger. And stinger is like just shooting pain down the arm, but I don't think there's an actual definition, but when I've spoken to the sports doctors and the physios and everything, when you're getting it down both arms, or if you're getting it in the arm and leg, or if you're getting it in the arm with weakness, that's not a stinger anymore. A stinger implies I took a hit and I've got nerve pain going down the arm and it should resolve.
Yeah.
So by definition, then stingers should resolve.
Is there a time limit on that?
No, I wouldn't say, but there's the usual 4 to 6 weeks for anything that's musculoskeletal.
Standard unit of orthopedic time.
Yeah.
Yeah. Okay. So, because you hear that phrase quite a bit. And so that would suggest there's been some kind of pull or traction injury or injury to the nerve in the neck that's caused shooting pain down the arm. But most of those will settle.
Yeah, so it can be, it's normally a hit actually rather than traction. Yeah. You can get traction. So sometimes you see people with normal MRI scans of their neck and they have the stinger down the arm. You scan the brachial plexus and you might see edema there, and it may be a stretch. And sometimes I saw one actually of a female rugby player about 4 months ago where she had profound weakness and they were like 1 to 2 out of 5, so very, very weak. And I thought, okay, 1 to 2 out of 5, that's significant. They're much more likely to need early surgery. To scan the neck, nothing there. It was brachial plexus, and after about 2 months, it recovered on its own. So yeah, you can get traction, but more often it's a hit to the nerve.
And what's interesting is whenever I, as a surgeon, talking to other surgeons, we kind of get labelled for operating all the time. Oh, this surgeon wants to operate, and yet most of the time is not operating. Most of the things everything you've discussed pretty much so far has been non-operative management.
Yeah.
If we talk about surgery, what are some of the common operations that you do for young sporting patients in the spine?
Yeah, so most common, to be honest, is the least interventional, which is an injection. Why do you do that? Because when you take a hit, when you have a nerve compression or an inflamed facet joint, they normally come to you only when initial measures, tablets, physio hasn't worked. So they want a quick reset on their inflammation. So a steroid injection is a good way of reducing inflammation in the joint or around the nerve, around the disc, and therefore reducing sensitivity, and then providing a better environment for rehab, providing a little bit more space in there. And also muscles are much more likely to activate if there isn't a trigger from the nerve, to them, inhibiting them. So
what are you injecting when you do these nerve root injections?
Yeah, good question. So generally a mixture of local anesthetic and steroid.
Okay.
Yeah. And
so that's a targeted anti-inflammatory where there's an area of swelling, almost as a little inflammation or a fire around the nerve root. And this is just a bucket of water to try and put the fire out.
Yeah, exactly. Yeah. And, and that analogy is great because sometimes it's a bit like putting salt on a wound. It can fire up a bit sometimes beforehand. And you can put more local anesthetic to prevent that flare up. But then the flip side of that is you get a bit of a dead arm or a bit of a dead leg on the day, which, normally, goes down. But yeah, that's the most common thing we do. And it gets, and the physios and sports docs love it. And younger people, fit and active conditioned people have a much higher rate of success with steroid injections. So you look really good as the guy doing them. We do them under X-ray, generally with sedation. So yeah, nearly all of them work on sportsmen. as you become less fit and less older and more deconditioned, they're less effective. So it tells you something there.
In the arthritic conditions,
Yeah,
it's less effective.
Exactly. But also, if you haven't preconditioned, you hadn't done the physio beforehand, you've
Yeah.
got a lot more to do afterwards,
Yeah.
a lot more ground to cover. So you're kind of giving a window. And if you've not got to that point of recovery before it gets re-inflamed, then you either got to do another one or look at an alternative.
Okay.
Next most common probably is either lumbar or cervical surgery. So a microdiscectomy is probably the next common. It's a prolapsed disc in the lumbar spine pressing on a nerve. And you can do really minimally invasive surgery, through really small incisions to remove the pressure off the nerve. You don't remove the whole disc between the bone. You just take that bit, which is compressing the nerve away. And then it's like anywhere between half an hour and an hour's operation. Get them up the same day. I generally keep them in overnight because that's what we prefer in this country.
Yeah.
You get an extra bit of physio, you get a bit of rest from kids at home or whatever.
Yeah.
And then I start physio really early as soon as the wound's healed, like 2.5 weeks afterwards.
And can we just talk about the discs? So in the spine, in your spinal column, you've got the bones, and then you've got the squidgy bits in between, or they may not be squidgy. How do you describe the structure of the spine to patients, and then the disc in particular?
So the bone is almost like a brick. It's the stable hard part of your spine, and between each bone, I call it a pillow. It's a cushion. Yeah. It's a pillow, basically. People like that.
Between the bricks.
Yeah, between the bricks. It's a pillow, it's a shock absorber, and it's an amazing thing. That's why when you're a teenager, you think you're just, you can do anything.
Yeah.
Nothing gets to you. Unfortunately, such is human biology, that part of aging is that as early as your late teens or your early 20s, there will be a reabsorption of the jelly, if you like, the what we call hydrophilic protein and a bit of water from there. So there's a slow process of what we call wearing down. It's actually a normal time-related process. The primary thing that determines how fast that goes is genetics,
right,
by far. And then smoking, and then activity, whatever activity you're doing. Obviously, if you're an Olympic weightlifter or a rugby player, it's going to be quicker. And then I show, if there's one that's much flatter and degenerate, I say that one there is like a pillow. This one here is like a gym mat. That one's like a picnic mat.
Right.
To
get firmer and flatter.
Yeah, firmer and flatter. And therefore, and with the anatomy in front, I can show the facet joints at the back and go, part of the function of that pillow is to protect the joint at the back, so there's not much pressure on it. If you've got a flatter pillow or a gym mat or a picnic mat, then there's going to be more stress on the joint, and therefore you get facet pain as well.
Right.
So I use the word pillow or cushion.
So I've not heard that before, because people talk about donuts and all kinds of different things, but I like that pillow.
I think people can't imagine a donut in their spine.
No, I think it's when people go, when the jam squirts out, that's the disc prolapse.
Yeah,
that's what I've heard people say.
Yeah.
So when you're doing a discectomy, as you say, you're only removing just a bit of the disc that's pressing on the nerve. And so it's actually quite a conserving procedure. You're not taking away the whole disc, which some people are concerned about.
Yeah, exactly. So that's the thing. Like people say, oh, what am I going to do without that piece of disc? I say, well, it's already out. It's not doing anything. It's being annoying. It's sitting in a place where it shouldn't be.
Yeah.
It's not doing you any favors. I'm not going to go in and take out the rest of the disc. I'm just going to take out that bit which is compressing the nerve away.
Yeah.
It's like, oh, well, can't more herniate? Yeah, unfortunately, there's a 10% risk over 10 years that more disc can herniate. But the alternative is I take the whole lot out, and you almost certainly get chronic low back pain. And it's much easier dealing with a reherniation than chronic low back pain.
So we've got injections, we've got microdiscectomy in the neck, cervical spine, and your lower back lumbar spine. Yeah,
so in terms of your neck, anterior cervical procedures is the most common thing I do, like in rugby players or Olympic sportsmen. I did all before the Olympics or after the Olympics. I did a bunch of different range of people, in a sailor, in a wheelchair basketball player, and there's quite a lot you do in hockey. But rugby really is the main place where you get cervical disc issues. Most of it you operate through the front of the neck, and people's instant response is, "Oh my God, that sounds horrendous." Actually, it's my favorite operation.
Yeah,
because all you do is cut the skin, and then you don't cut anything after that.
Yeah.
It's an operation that's been going since 1969. The approach has not changed, as you know, because you would have learnt it for your FRCS. I'm sure you've forgotten about it. But it hasn't. The approach has not changed. It's the same.
You're just moving things out of the way. You're not cutting anything.
50 years. What has changed, as you know, is the implant you put in. And even in the last 10 years, there's been a significant change in the quality of the implants that we put in very small implants in the neck.
Just mention the implants, because you're talking about, so what you're talking about is when someone's had a disc prolapse in the neck that's pressing on the nerve or causing pain, that you'll make an incision in the neck, usually in the skin creases. You won't cut anything else. There's a lot of important structures there. You'll just move those out of the way, keep them safe. You'll get to the disc, and then you're going to do you'll do a discectomy there.
Yeah, so that's right. So there's midline structures. Obviously, you've got your voice pipe, your box, the windpipe, food pipe, vessels, everything like that. And you just carefully retract them. If you're used to that, it literally takes 7 to 10 minutes to get down to the actual bone in the disc. You check it's the right level through X-ray, obviously.
Yeah.
Then you take that disc out, and the back of the disc can often be bone as well. So you might have to shave bone, bone pressing on nerve, and then you make sure it's clear, and then you put an implant in.
What are the implants?
Yeah, so in a younger person who has otherwise normal anatomy, where there's not much in the way of facet degeneration, we put, a disc replacement, I think, is the most ideal thing to put in. People were skeptical of it. First, they said, oh, it's, non-inferior, it's more expensive, but it's not that much different. But actually, as time has gone on, and now they've been going for some of them nearly 20 years, it's evident that actually the data on most of them, because it's very implant dependent, most of them actually with time have a slightly greater benefit than a fusion in the right patient.
And fusion is when you take the disc out and you fuse the bones together with plates and screws, and it becomes a rigid construct. Those two bricks, as it were, the bones are joined together. What's the advantage of the disc over the fusion?
Yeah, so these days the fusion is a little cage with screws attached to the cage. I don't put a plate on anymore. So obviously
I'm showing my age.
Yeah. So no, some people still put plates on, but it's much less used now.
Yeah.
So that fuses that level. As it says on the box, you fuse that level, it doesn't move anymore. You still get full range of movement afterwards. The results are still excellent, but there's a higher rate of adjacent level stresses through the other level. Because let's say the total stress going through your neck in total in your daily activities is 100, whatever the units is.
Yeah.
It's split between all those levels from C1 to C7.
Yeah.
If you take one out, it's split between 6. Yeah,
Gotcha.
so greater force at each level, especially at the level above or below, generally above, and that's the adjacent level. So there's an accelerated amount of adjacent level degeneration, the theory of the disc replacement, because there's movement there.
Yeah.
There is less
So that's
stress.
literally a thing that is like an artificial pillar or a disc that you put in there.
Yeah.
And it does similar job.
Yeah. But like all technology, it goes up like that. And everyone's really excited about it. Then you see, oh, God, there's a problem here, problem there, complication here, new complication. We never had fusion, it went down. And then it's now rising up as corrections have been made. And we realize that actually it was very implant dependent. There are certain implants that have done really well. There's a few that did really badly that have been pushed off the market. There's a few that do okay.
But such is the medical innovation and, progress, as long as the things aren't working and move to the side.
Yeah, yeah.
Could you tell the difference if someone's had a fusion or a disc replacement in terms of their neck, range of motion, their head? Could you tell?
No, if you line some patients up who are all 40 years old, let's say, or 45 for argument's sake, probably not. Same surgeon.
Okay.
Yeah. No, because my one-level fusions all pretty much get a full range of movement.
Right.
It's more in the longer term, like what's going to happen 10, 15 years down the line. Just to be clear, there's quite a lot of people that aren't suitable for a disc replacement based on the anatomy, how worn down it is, what the adjacent levels are. In this country, a disc replacement is more expensive.
Yeah.
And it can make the difference, especially in government hospitals or even insurance based where the hospital loses money on it. So if you don't need to put one in, then, and it's not suitable and it doesn't fit the criteria, then don't put it in, basically.
But your risk of adjacent level disease, the chance of you getting further arthritic change above that level or below that level, are they reduced if you do a disc replacement against a diffusion?
Yeah, in suitable patients. Obviously, if you have like very arthritic facet joints at that level, then that's going to hurt with a disc replacement because it moves. So you might need resurgery for other reasons.
Yeah.
But yeah, it's been shown a number of times now that adjacent level disease symptomatic is reduced with a disc replacement.
Great. Any other operations?
Yeah, sometimes, especially in rugby players, do posterior cervical surgery.
Yeah, that's not a thing you hear about very much.
Yeah, so foraminotomy is literally the only thing about the back of the neck is there's huge musculature. Yeah, so
especially in rugby players.
Yeah, I mean exactly. So, but I think of any orthopedic or musculoskeletal operation, this has the highest rate of wound breakdown and infection because of the tension.
Yeah.
As opposed to the complete opposite here, which I can't remember the last elective procedure I did, front of the neck, where the wound didn't just heal.
Yeah.
The back of the neck is the opposite. So there's thick musculature, a lot more muscle to heal. But again, you can make small incisions, and it's literally, instead of retracting the midline structures, putting an implant in, worrying about what that does, you're just shaving bone. But all you're doing is creating a bit more space. You're not necessarily dealing with the thing at the front, which is the disc bulge or prolapse, which is causing the compression.
Yeah.
But, you know, historically, it's been used a lot in rugby, for instance, because if you've got a deadline, you've got the Rugby World Cup coming up in 3 months' time.
Yeah.
The foraminotomy is the one that'll get you back there. And, you know, you've discussed it with your surgeon, and you've said, look, if it recurs again, then I'm happy to deal with it, but I just need to get back on the road.
Okay.
And that's an option.
And the foraminotomy is when you're going through the back and you're clearing bone around the nerve just to give it space to breathe?
Yeah. So you're literally shaving bone above it. Most of the procedure is opening and closing.
Yeah.
If you're doing a one-level, one-side foraminotomy, that actual foraminotomy bit takes about 10 minutes.
Yeah.
So most of it's set up. You know, you've got to get their head in the old Mayfield tongs, which holds the head.
Yeah.
You've got to do the incision. You've got to dissect down to the muscle. It bleeds more at the back of the neck, and then it takes time to close. And because it's got a high rate of wound issues, you've got to close it in multiple layers. So as opposed to this, which takes like 2 minutes to close.
Gotcha. Okay. Any other operations we should know about?
So you sometimes repair pars injuries. So I generally try and avoid as much as possible, because I think a lot of the people coming through are very young. And, you know, you can only give them an 85% guarantee, whatever it is, that they'll get back to their elite sport. As we know, my view on it is just only as a last resort. There are some people that do it earlier. Why? Because we know for sure that it's not only necessarily one side, one level. You can get it then get it on the other side. You can then get it at another level.
Yeah.
What do you do then? Career's over.
Yeah.
Whereas if you treat it conservatively and you're successful, then you can still play with all of those. So it's basically one screw. You have to image guide it, preferably with navigation. So, you know, you can use 3D navigation in the theatre to guide the screw through. And then in terms of other surgery like fusions and things, generally at the elite sport level, if you're having a fusion, then that's the end of your career.
Yeah.
I've got 1 or 2 exceptions to that.
Okay.
An Olympic triathlete that had a front and, you know, a big fusion at the base of their spine, through the front and through the back. And qualified for the next Olympics.
Yeah. I see a lot of triathletes. They're not normal people.
No.
You mentioned, what was interesting there was you mentioned navigation. So I want to ask you about the latest techniques or any innovations in spine surgery.
Yeah, so I think now navigation's become more of the normal, to be able to have a 3D image in the theatre rather than relying on your radiographer to get a good AP and a good lateral, a good side view, a good front view. So having a 3D image. No technology is without its potential issues.
Or limitations, yeah.
Yeah, it's, you know, you've got to put a reference point there.
Yeah.
And you've got to not knock that reference point. I mean, that seems a bit archaic, but that's the But if you knock the reference point, the 3D image goes out of sync.
Right.
If it accidentally hits your elbow. But once you're aware of the setup and you have it all in the right place, and hopefully with technology, you're not so reliant on that.
And navigation is like using sat-nav to basically guide your implant screws, wires into exactly where you want to put them.
In a 3D, So you can see live, you can see from every view, from the top, from the bottom, from the side, that screw or implant's going in the right place.
Because historically, there was definitely room for error, because you were looking at 2 views, a front view and a side view, not 3D, and so you could still be off.
Yeah, no, exactly. So, you know, for instance, putting screws in, you know, accuracy with putting them with AP, you know, with just X-rays and 2 views. So, you know, if you're a decent surgeon, it's up to 90%, but the navigation can get you way up from that 98%. There's not 100%.
Yeah.
There is robotics, which again took off like that, and then, you know, one by one, people started having some issues with it or limitations. So it's not that there's a negative with it. It's just it takes a lot more time. There are studies, of course, that show it's even slightly more accurate. But actually, if you speak to most spine surgeons now, a lot of them only using it in certain situations or not using it much at all. And I think that technology is not there to go. I think it's just having a bit like cervical disc replacement, a bit of a lull as people work out where it's used and technology improving. I think it'll just take off again.
Yeah.
I think most of spine surgery is about minimally invasive techniques.
Yeah. Historically, it was big incisions, you know, flaying open the back, as it were.
Yeah.
You know, being slightly uncouth. And now, whenever I see spine pain, I saw someone the other day, they were like tiny little incisions all over his back. And I was like, geez, this is getting less and less invasive.
Yeah, no, exactly. Like, you know, I mean, you can do a microdiscectomy through that incision, whether it's endoscopic or through a tube or with normal retractors. They're small incisions now.
Yeah.
If you're doing a 2-level or 1-level fusion, they used to make, whatever that is, 30 centimeter incisions.
That's what I'm used to from when I was a junior doctor.
Yeah. If you're doing a lateral fusion, you can do fusions through the side of the spine as well.
Yeah.
So it's one of my favorite operations as well, because again, it's much like this one. You're basically cutting the skin, and then you're parting muscles, your transverses, all those muscles there, and you're going down to the bone, and you're like, oh, is that it? In a thin patient, it's unbelievable. You can literally cut only the skin and the fat, and that's it. If it's the right patient, right size, and all this kind of stuff, you can be putting a big cage in and be done in 50 minutes.
The less you can cut a structure, the better.
Yeah.
For healing and recovery.
Yeah.
What is endoscopic spine surgery?
Yeah, so it's a bit like, doing a knee arthroscopy, but in the spine. Yeah, keyhole. And again, it's another technology that took off, and I was doing it years and years ago. And then I think a lot of people then went off it. If you went into the private hospitals that we were all working at before, you'd find them all sitting in the corner of the room because it took off massively. And then people realized it was taking too long and it wasn't improving their outcomes. Now endoscopic surgery is taking a big lift off again because the indications have increased.
So this means you can do a keyhole discectomy now. If someone's got disc prolapse, you can operate. I mean, you're doing quite small incisions anyway with your microscope, but you could go even smaller and do keyhole.
Yeah, they're very much smaller. I think you're talking about 1 or 2 millimeters. So for an endoscopic, and you're probably about 18 millimeters is the incision. If I'm doing a micro disc with microscope in a tube or whatever, it's like 20. So you're talking about 2 millimeters more. So it's actually not that much in terms of the other thing. The endoscopic surgery is that you've got to be careful of your indications.
Yeah.
So some of us do see, that's the thing about any technology, you've got to use it in the right patient at the right time. So I've seen quite a lot of people come back from endoscopic surgery. But yeah, I think it's definitely one of the ways forward. And people are using it for fusions now. But again, the point of a fusion is, when you're going and taking the disc out and putting a cage in there, you've got to actually prep it properly and got to make sure whichever way you're doing it, that you're doing the right procedure and not just doing it through a small incision.
And there comes a point where you can compromise the outcome for the sake of
exactly.
that.
Exactly, yeah. So obviously people focus on the skin incision, but minimally invasive surgery actually for me is more about the invasiveness inside.
Yeah.
So you might make let's say a skin incision for a fusion that big, but inside you're doing really very little.
Yeah.
Or you could actually make it that big and you're doing a lot of damage inside. Yeah. But it's
a misnomer because people do often just look at the size of the scar. I mean, for a hip surgery, for instance, for hip replacements, it came down to the length of the incision in the skin.
Yeah.
And,
so it depends what kind of, because there's muscles there, there's joints there, there's screws you're putting in, what kind of decompression are you doing? Yeah, my micro, discectomy incision now has got smaller and smaller and smaller as the years gone. You just need enough space I treat it like a window. People say, how do you do a micro discectomy with that incision? Because you can, with the microscope, you can look left, you can look right. You don't need a big window. That's more psychological.
And that was more when we were doing more open surgery before the era of the microscope.
Yeah. I hardly ever do wide open surgery now.
Yeah.
When you're doing revision, fusions, and extensions, sure, you most often have to open the whole thing up and flay it open. But it's just not often have to do that now, because also you can put screws, as percutaneously just through mini holes.
Yeah.
And that's what I do 90% of the time now.
For members of the public, any physios or GPs listening, what are key things they should look out as early warning signs for spine issues?
So obviously basic things first. So if you got, back pain, which everybody gets at some point, and, you've got the right advice and you're taking the right tablets and you've seen the physio, and then let's say, for argument's sake, 3 months down the line, it's still there. You think, oh, well, why is that? Because that 85% of people would have got better by now. Why am I that?
Yeah, but there's a stat, isn't it, that 80-90% of people are back to normal within 6 weeks after back pain?
So I think 6 to 8 weeks is about 80%. By kind of 3 or 4 months, it's 85 to 90%.
Right.
So I think because of that stat, then it's a good time to MRI scan. Why am I one of those 20% or 50% or 10% that have not got better? So that's not a red flag, but it's like, okay, let's find out. Is it because actually, in me, with my body, with that anatomy, it's just one of those ones that's going to take longer?
Yeah.
Or is it there's something else there that I need to know about?
Yeah.
And you're better off doing a scan which has no radiation. As you know, MRI scans they're not X-rays, they're not CTs. They're noisy, they're a little bit pricey, but there's little harm from doing them. So that's one thing. And I think with leg pain, similarly.
Why is leg pain important?
Yeah, leg pain is nerve-related pain, as you know. So anything compressing the nerve. So most of the time it's a disc. It can be joint, it can be bone. Occasionally it can be a cyst, like a facet cyst.
Yeah.
Sometimes these facet cysts can be really big. And sometimes you do a scan and the spine's normal, then you go, okay, where else is it coming from?
Yeah.
Is it coming peripheral, like in the buttock, in the knee,
Yeah.
anywhere else?
So if someone's getting leg pain, that suggests that a nerve is being pressed in the spine upstream.
Most of the time, yeah.
And what is the risk of leaving leg pain? Say someone says, I can manage the pain. What is the risk of leaving that?
Yeah, it's a really good question. So really, I guess in the first 3 months, there isn't much of a risk, as long as there's no weakness.
Yeah.
So that's the main thing, neurological weakness. And the disc prolapse isn't so big that it's compromising the nerves, the bowel and bladder, obviously. But I think there's a decent amount of evidence that shows that once you get to above kind of 5-6 months, the chance that you get more irreversible damage to the nerve, which gives you longer term pain, slowly, very slowly, not that there's a sharp increase, very slowly increases with time. So then you say, okay, well, when is the best time to consider surgery? You've tried conservative measures, physios, anti-inflammatories, you've done 2 injections or whatever, let's say. At what point do you say, okay, look, in my experience, the pros outweigh the cons in terms of doing surgery? And I think that depends on your age, your activity level. What do you want to get back to?
Yeah.
So if you're Kash Akhtar and you've just suddenly started lifting 20 kilos for the first time in your life, no, if you're, let's say, you want to get back to you're an amateur triathlete, you work in a bank, but you want to do triathlon, you compete 2-3 times a year. There's a lot of our patients do.
Very classic, yeah.
So if you want to get back to that level, then you veer towards earlier. So I'd probably say to them at 6 months and say, okay, look, at 6 months, we know at this stage, if you want the best chance for you to get back to perform at the level you want, then this is probably now the time to intervene. If you want to do another injection, that's fine. But just to let you know that the risk of more permanent damage slowly increases with this time. So I give people chance of getting a very good outcome at 3 to 6 months is about 90, I'd say more than 90% in my hands. At 12 months, I'd put it at probably 85%.
Yeah, it goes
at
down.
18 months, I'd put it at 70%.
Right.
It's harder to get back to where you want to, and it takes a lot longer.
And we see that in knees as well. And more so in knees because we're not dealing with nerves. Generally, you can leave it be, and it's a lifestyle decision at times. But the longer you leave it, the more deconditioned you are, the longer it takes to get back to that level. With the nerves being squeezed, you can get pain. But obviously, weakness is the other thing. You mentioned weakness. Why is weakness a concern?
Yeah, obviously, there are different nerve bundles involved in weakness, and the timelines are completely different. So if someone comes with pain and weakness, I separate them out and I say there are different management plans for pain and weakness. The pain one we've talked about, so we don't have to go over that. Weakness is really clear, and there's a really good paper that's come out by my colleague Ahmed Sadek, which I was part of, on foot drop, which is an excellent paper. It's on LinkedIn under his name, that summarizes like a mental analysis of all the papers on foot drop. So what was reassuring about that paper is my experience and also my practice. We know that if you have a foot drop, like a weak foot, and we know that quite a few people do get better in that first 6 weeks. And that's probably around 50, 60%, maybe slightly more than that at times, do get better on their own. So that's why in the UK, we wait up to 6 weeks. In some countries, Germany, US, whatever, it's not uncommon to see them operate 2 weeks. But, we're a conservative country, so we generally leave that 6 weeks. What happens at that point? We know at that point that between 6 and 12 weeks, it kind of falls off a cliff a bit. So I would say about 85% of my people, roughly, my patients get significant improvement or full power back if we have surgery around, let's say, the 5-6 week mark. I'd say at 3 months, for whatever reason, if they come at that point, that probably drops down to 50. And at 6 months, I'd say it's probably 5%. So it kind of falls off a cliff. So your timelines for weakness are much different. So if a patient comes 4 weeks down the line and they've had weakness, you've got to start bringing in surgery into that conversation. But I say, look, there's still a chance. And in my experience, if they get better between weeks 3 and 6. So I say, look, in my experience, it gets better between weeks 3 and 6, the weakness, when it does. So I'm going to wait another week. And then we're going to book you a date for surgery if you agree to it. And in that week, you're going to let me know if it gets better. And if it does, then we won't do it.
Got you. So to round up, and we zoom out, what's the best thing people can do to look after their spines? People in their 30s, 40s, 50s.
Yeah, I think loads of things. I think there are different aspects you can look at. So I think without a doubt, movement is by far the best thing for it. What kind of movement? So low impact activities, walking's great, getting on an exercise bike, getting on the cross trainer, getting in the swimming pool, front crawl, backstroke swimming. Breaststroke does put a bit of strain on the back with the hyperextension. Get involved in reformer Pilates, get a good strength and conditioning coach. If you've got an issue, go to a physio. If you don't have an issue, get an S&C coach that is really qualified. There are different abilities and different qualifications from them. Whatever exercise you do, build mobility first, then get the right muscles activated, and then build in strength. I'm an amazing fan of reformer Pilates. I think it ticks all those boxes and it preps you for life, really. But there are different aspects of that because, like anything, everything is sleep dependent. You can't do anything without sleep. The most important thing actually above exercise is sleep, because without that, you can't exercise properly. Your stress level goes up, cortisol level goes up, inflammation, chance of injury. And then with that, obviously, all the things that raise inflammation like sleep, diet, stress, alcohol,
nutrition, all these things.
all those kind of things. So I think movement is the key. And for a lot of people, not us necessarily, we're at a desk sometimes. Most people have a desk-based job. You've got to get up and move.
Okay.
We weren't designed for that. So movement's the answer.
Monty, thank you very much. It's been incredibly practical and insightful conversations. You've been listening to Exploring Health with Cleveland Clinic London. I'm Kash Akhtar. It's been a pleasure to have Mr Alexander Montgomery with me on today's episode. If you've been listening or watching and you want to take charge of your health, please check out the links in the show notes for more information. If you found this conversation valuable, please don't forget to subscribe, leave a review, and share it with someone who needs to hear this. Until next time, thank you.